Welcome to the 15th SNI and SNI Digital Baghdad Neurosurgery online meeting, August 7th, 2022. The meeting originator and coordinator is Samer Haas, Universities of Baghdad and Cincinnati. Professor A. Hadi Al-Khalili, former chair of the Department of Neurosurgery, Baghdad University. He is speaking on highlights of neurosurgical history in Iraq.
So my talk is very simple. It is about highlights of neurosurgical history in Iraq and what has been done over the past decades. In fact, we are honored to have the history of modern neurosurgery linked to Iraq, where Sir Victor Horsley, who is the founder of modern neurosurgery, just prior to Harvey Cushing, who is the real founder of modern neurosurgery. He was buried in Iraq. He came with the British Army in 1916, and then a few weeks later, he suffered from heat stroke, and then he was comatose for 2 days, and then he died and buried in Amara, which is in just south of Baghdad, here in Amara, and there is the war cemetery, and that is the names of all the people who are buried there. And you can see that the bridge over Tigris is being bent nearly 90 degrees to avoid going through the cemetery. So that's the plaque here, and I'm standing beside it. That's in 1981, so I look a bit younger. Professor Najib Yaqoubi, he was the founder of neurosurgery in the past. He started the neurosurgery in the 50s, and he trained in Europe, and then he established and started the neurosurgical hospital in Baghdad in 1960. His main interest was Moyne's leucotomy of psychosurgery, and he did trauma and some other surgical procedures. And then we have Malcolm Parhard. He is an Assyrian from the north of Iraq. He graduated from Edinburgh University and trained in Stockholm with Oliver Corona, and then back to Iraq. And then his main interest was spinal surgery, and he died in 1960. He lived by 3 eminent physicians here in the United States. Professor Abdul Rasul Sadiq was the third in line, and he was graduated from Baghdad University in 1948, trained in US in NYU in 1960 to 65, and back to Iraq 65 and 67. I was honored to have been one of his students when we were medical students at 5th year when we studied neurosurgery. And then he was back to New York in 1967 and remained in NYU as a faculty, and then went to private practice. The real founder of modern neurosurgery, of course, is Professor Saad al-Witri, who graduated in 1956 from Baghdad Medical School and went to London in 1958, and then 1962 got his FRCS, and in 1965 returned to Iraq to start his task of building up the neurosurgical practice in the country. I graduated 1966, and in 1971 went to UK, trained, as I said, in Germany and Switzerland, Canada, and 1976 back. And I have added to my professional work, I had some interest in research, which I had implemented and did some research work in Iraq. In the 90s or early 90s, a total of 12 qualified neurosurgeons were running the show in Iraq. And most of them were qualified with FRCS from UK, but one colleague, he came from Germany in Berlin. He had his training, and the other one qualified from France. Neurosurgical services in 1950s started at Baghdad Medical School Teaching Hospital under the auspices of or leadership of Professor Yaqoubi. And then in 1960, as I said before, specialized hospitals started in Iraq only for neurosurgery, nothing else. And then 1990, there was surgical specialties hospital related linked to the medical school, and had about 20 stories, 20 floors, and each subspecialty has a floor. There's no general medicine, no general surgery, no OBGYN, only special surgical lines. In 2002, Dr. Saad Al-Witri Neurosciences Hospital, affiliated with Ministry of Health, was established. And they are running a great show there with science and the upgrading of the services. Number of neurosurgeons in Iraq in 1999, total was 48 neurosurgeons. Worked in 12 neurosurgical centers. At that time, population of Iraq was 27 million. So we had one neurosurgeon serving nearly 500,000 population at that time. And when I was in England in mid-70s, the rate was, again, same thing, one neurosurgeon to 500,000 population at that time. Diagnostic facilities available before we had the CT scan in 1978 was very simple, plain X-ray, myelography using myodil with all its complications and the problems. We didn't have anything else. We have air encephalography as a means of diagnosing, and angiography using direct carotid puncture, and the technetium brain scan. That's all we had at that time. Then in 1978, two CT scans were installed, one in the neurosurgical hospital and the other in the University Teaching Hospital in Baghdad. Surgical procedures were done in all the centers. In fact, they did almost everything, trauma, neoplasm, infection, abscesses, and everything else. But something peculiar to Iraq is hydatid cyst, which is called by one of our professors, Professor Khalid Naji, as cancer of Iraq, because it is really very dangerous if you don't deal with it properly. And this is a solitary cyst here, behaving like space-occupying lesion. It's very silent until it becomes progressive in size and then produces neurological problems, or it can be multiple, and in which case treatment is really impossible to cure the patient. In this case, when it's solitary, you can, if it's not ruptured, you can remove it and the patient is really safe and cured. Neurosurgical training in the country started after 1980. There was no scholarship because of the war in Iraq, the Iraq-Iran war, and then we had the 1991 war and all the problems. So nobody can go abroad to get more training. So training was basically by apprenticeship, but in 1986, an Iraqi Board of Medical Specialties was established, and that covers the major medical specialties. But in 1989, the Iraqi Board of Neurosurgery was established. And to get into the Iraqi Neurosurgical Board, you have to be a graduate of Iraqi medical school or any recognized other medical school, which was not the case at that time because of the difficulties in the country. So nobody will come from outside Iraq. And then you have to complete 1 year of internship, and then you pass qualifying test before you be accepted to train in the neurosurgical board. To get the neurosurgical certification of the Iraqi board, you have to have 5 years of training and rotation in pediatric and adult neurosurgery, submitting a research project, and you have to have a mentor for that project, and you have to defend it in front of a committee, and then pass written and oral exams, and then you will be qualified neurosurgeon. There is another means of getting certification. That's the Arab Board of Medical Specialties, which is based in Damascus, Syria, and established in 1978. It covers, again, major specialties, but in 1998 started neurosurgical board, but not in Iraq. In Iraq started 2007. We had before, well, 2000, after and before microneurosurgery, we had the brain navigator, brain lab, and we have brain endoscopy. In fact, before we had brain endoscopy, we used to use the pediatric cystoscope to get biopsy from the brain tumors in case it's required. And 2004, of course, until 2022, the current year, we have great advancement by our colleagues in Iraq in general. And Dr. Munir, I hope he will touch on that in details later on. Research, we had clinical research, we had experimental research, we had some innovations as well. Clinical research, as I said, it is mandatory for any students of the Iraqi board to have projects of research, and that will be part of his requirement. And we have many individual and joint projects in different topics on clinical problems in neurosurgery, including abscesses and tumors and everything else. Experimental, we had some project on the cranial nerve degeneration, because it was found that third nerve can regenerate, but in different ways. The nerve fibers will go differently and have different function. So we did a good project on that, but unfortunately there was some problem at the end. Then we had spinal cord grafting in mice, and we proved that spinal cord grafting can be done. We used the sciatic nerve for grafting, hemichordotomy area, and it was published in the Spine journal in Edinburgh. And then we have proceeded to dogs, and then with dogs we had implemented sural nerve graft, added to it omentum, enforced by omental graft. Some research on biofeedback, but at one time there was treatment of epilepsy when you can take the EEG of the patient and then analyze it and get the alpha waves of the patient to make him hear his alpha waves, supposedly to reduce the resistant type of epilepsy. Hydatid cyst of the brain and orbit, did a lot of experimentation on that with glove filled with water and sacks, and then did CT scan to see the changes and the density of the CT scan to differentiate it from tumor. Innovation, we had some scale for setting sun sign, just to quantitate the setting sun sign, and then had instruments for Hydatid based on this kids game, and there is some simple sign to test the power of coordination and proprioception, and ophthalmoscopy made easy by very, very simple way. But you can have medical student, maybe in 5 minutes, they will be able to see the fundus and then have to know about what's going on in the fundus. Very simple way of doing it. Current number of neurosurgeons, more than 200 neurosurgeons, including around 10 female neurosurgeons and over 100 residents now in Iraq, and more than 20 neurosurgical centers with a new technology available in most of them. Population of Iraq around 40 million, and now it is one neurosurgeon serving 200,000 population. So the torch was passed to our younger colleagues, younger leaders to take over, and we are proud of their leadership, achievements, and progress, and thank you.
If you have any comment, Dr. Osman, Dr. Lazarev, Dr. Awsaf, and Dr. Ali Khansari.
If you don't mind, I say something to share with our other young colleague.
Yeah.
When Dr. Khalili talked about Dr. Victor Horsley, it is in the history of the neurosurgery, the first epilepsy surgery done in 1884 by Dr. Horsley was on the 12-year-old young boy who was kicked on the head with a donkey, and he had damage to his brain and had constant seizure. And he operated, even at that time, 1884, to remove the scar, and the child recovered. It is written in the British Journal of the Medicine. I saw the original one, which we had it in our library at UCLA.
I would like to add some, I would like to ask a question for Dr. Al-Khalili, just to to have the full picture, because most of the people, I think, they don't know about it. Like Dr. Khalili have a strong career in Iraq, building a department and teaching people, treating patients. But at the end of his Iraq time, there is a huge event. I think changed a lot, and this is part of the story. And I would like Dr. Khalili just to inform everybody about the event, about his kidnapping and what happened, because I think this is part of the picture and part of the story.
Yeah. Well, life in Iraq was difficult really for everybody before 2003 and after, with the sanction and with the lack of everything, the budget or the salary of the doctor was $3 a month. So he has to live with that. And we have lack of papers, we have lack of shunts, we have lack of oxygen. Many operation lists were canceled because we don't have oxygen. We don't have any air conditioning in the theater. So you have the sweat, you possibly use maybe 2 liters literally of sweat during 6 hours of surgery. So you have to feed yourself with lots of water. So it was difficult time at that time. In 2003, I had a problem. I was my car was taken by force by 3 people with 2 guns with the hands of each one of them. And then I was going to be shot at that time. So they took the car from my driveway, and then I went inside, and they shot on the door, one bullet. But fortunately, the door was thick, so nothing happened. But they took the car. But the more important event happened in 2004 when I was kidnapped. I think because I created the big society in Iraq called Environment and Culture Rescue Society, with many distinguished people, Iraqi people from all sects of the society. So I was the president of that society. I think that created a lot of fuss in Iraq at that time. So I was kidnapped then and put in the trunk of the car with handcuffs and blindfolded. And then I was taken somewhere outside the suburb of Baghdad, locked in, and then they wanted $500,000 ransom, $500,000. And then about just more than 3 days, I was released, but they accepted $30,000. I was a little upset because they realized that I'm not worth $500,000. I just worth 30,000. So I was released then. At that time, I was not really in distress at all. First, maybe a few seconds, few moments, I was distressed. Then I accepted the reality, and that's it. And once the kidnapper was beside me, it asked him to take a picture for me with his phone. So he took a picture. He said, "That's no good. Put the handcuffs and blindfold and take a picture." And then I smiled at the phone. But of course, he did not send me that picture because he would be then expose himself. So after that, I stayed in Iraq, but they asked me to leave the country, and then I stayed just for a few months. And they asked me to leave the country, not to stay at all. That's why from 2004 until now, I did not go to Iraq. I was offered to be the Minister of Health, Minister of Higher Education a few times, lately and 2 years ago, but I apologized because I thought I can help from here rather than to be a minister in Iraq. I was here in Washington as a cultural attaché, dealing with the link of Iraqi health and higher education with the American institutions, and they have lots of activities. I have a big conference at the Library of Congress, and the video of that conference, about 5 hours, you can see it at the website of the Library of Congress up till now. I gathered about 300 Iraqi American academics, leading professors in the country, with Professor Peter Agre, the Nobel Prize winner, to attend that meeting. And for 3 days, we had a big, 2 days, we had a big conference here at the National, hosted by the National Academies of Sciences, and created a project called Together for Iraq with 43 committees in each branch of life, of science, 18 about in medicine and the rest in education and law and everything, and linked to Iraqi committees, but unfortunately that did not materialize and did not work because of the situation in Iraq. So many things happened, and we are here trying to help Iraq in whatever way we can.
Bless you. You're just so wonderful, wonderful things you're doing. And we appreciate it.
Back to Dr. Khalili, and this mostly for the students. When we say cyst, and we look at the cyst like a big ball, balloon, blood on the CAT scan, to operate an hydatid cyst is like disarm an atomic bomb. Yes. Because if the cyst explodes, all the hydatids contained within the cyst, they spread over, no? So it's quite an technical and surgical achievement to operate on hydatid cyst of the size that Professor Khalili showed there, no? And I agree with the statements that Dr. Osman said about the research as well, no? The relevance of the research. And the final statement is an admirable work and commitment to your country that you're doing, Dr. Khalili, no?
Thank you. Thank you so much.
Dr. Khalil, I thought you had a very interesting presentation you had. The history is very interesting in Iraq, and it again supports the fact that there are bright people everywhere in the world who have created many great things. You mentioned about experimenting with spinal cord transection and in dogs and so forth. Were you able to see some forms of recovery in those experiments?
Yes, indeed. It was after we finished with the mice, we proceeded with middle animals, the dog, and then it was a project for a PhD student, a vet doctor, and she did. We used, and as I said, in mice we used the sciatic nerve for the mouse, and we had definite histological recovery and hypertrophy of the axons going through the gap. But for the dogs, we use the sural nerve. And then we had 4 groups of dogs, one sural nerve minced graft. We used minced graft, sciatic nerve in both experiments, minced nerve graft. So we used minced sural nerve graft as group 1, group 2 as a control, group 3 as minced graft with pedicle of omentum coming through subcutaneously coming to the spine and sutured with the dura. And the 4th one, only omental graft. And then with the 3rd group, that's both sural nerve, minced graft, and omental, we have almost full recovery of the paraplegia. And we have video for that. But the video, you know, at the time of sanction, everything was difficult, and the video does not show exactly the color of before when the dog has complete hemiplegia, paraplegia, and then recovery, complete recovery. The video picture, they don't show the same color. So I was skeptical because people may doubt that, but it is truly full recovery of the paraplegia in this group with minced sural graft, sural nerve, and supplemented by omental graft. Omental graft, we got the idea from one of our professors in south of Iraq, in Basra, Dr. Mohammed Hussein Saadi, the late Mohammed Hussein Saadi. Again, he was an innovative surgeon. He used to go for the prostate through the perineum. So he used this omental graft for a treatment of elephantiasis. He brings the omentum under all the ligaments going to the thigh, and then the elephantiasis improved significantly. So I have the video with me here for these dogs, and she got her PhD with distinction, the girl, but unfortunately she was killed with her daughter and this mess which we had in Iraq, and it was very, very sad for me personally, for Iraq in general.
It's excellent, excellent work. It's dramatic work. We published some articles in Surgical Neurology International by Dr. Cannavaro, who was doing similar work with different techniques in mice and dogs, and then in monkeys, in which he was experimenting with can you restore spinal cord function after transection? And they were able to show that you can, just as you did. Were you able to publish that work that this young woman did with you?
No, unfortunately, but I have the thesis with me here.
Well, if we could see the video. If it's up to Samar, but the other thing I would suggest is, if you want, we can publish the video or even your short summary of this experiment.
I would love to.
Publish them in Surgical Neurology International. I think it's very important for the literature to know this. Dr. Cannavaro, with his work, has undergone enormous criticism because people don't believe it. But I can tell you the experiments were done in multiple laboratories around the world. And it is outstanding work, and the work you're doing is very interesting. There was a doctor in the United States by the name of Harry Goldstein who used Omentum. You probably know the name.
We corresponded with him, by the way.
Yes, and he was also underwent tremendous criticism. He was a general surgeon, but he used the Omentum on the spinal cord and the brain to revascularize it. Because of just what you said, it has, as in the leg, it has a huge vascularity and amazing absorption powers in the tissue for proteins and fluid and so forth. So you were ahead of your time, and I think you could even write either a small short editorial or a letter to the editor with your video. We'll publish them, and I think she will get credit. And I'm very sad to hear that she's not alive, but you will be able to give her credit for what she has done. It's very important work.
I would love that, especially for her. I had, in fact, the idea of using the Omentum for treatment of idiopathic intracranial pressure at one time, but I did not do that.
Well, it's very, very creative, very good. And the next thing you said was that you were, I thought I understood that you were doing experiments with cysts in the brain. And did you put balloons in the brain to do that, and measure their effect? How did you do that?
We did that at the beginning of the CT scan. In fact, it was in 1978 or 79. I got a surgical glove filled it with water and then amputated the thumb to make it a smaller sac, and then one of the other fingers to have a bigger sac, and I put one in the orbit with some slices of fat in the orbit to simulate orbital fat, and then one sac was put in the cranium itself, and then did CT scan for that cranium and see the density, because in the orbit there's something peculiar about this cyst. It is interpreted by the CT scan as tumor, a solid tumor, because of the physics problem of transition from bone to fat, that immediate transition, so the computer will be confused. So many times I open the cranium just to go to from the roof of the orbit to get to the tumor in the orbit, and then I'm disappointed to see just it is a sac filled with fluid. That's why I did this experimentation, and then it proved that the cyst in the orbit has 5 to 7 times more dense than cyst anywhere in the body.
Very interesting.
Because of the location in the orbit, bone all around, fat inside, complete discrepancy between the density of the two. There's nothing in between, no soft tissue, just bone and then fat. So the computer interpreted that as a tumor. And it was published, in fact, in American Journal of Computerized Radiology.
It's a very interesting observation. We received over the years many papers on intracranial hemorrhage, which, and you know this subject well, about people in various countries taking a group of patients with intracranial hemorrhage and removing them and reporting their success. What bothered me, and you know about the randomized studies that were done in England, which have some very serious flaws, but remain the major standard papers in the world. There's some additional papers, but it didn't make any different information. And to me, it was always a very reasonable idea. And you could do this with a balloon tip catheters, to put a catheter in the, say, the frontal lobe, blow up the balloon, and you could measure this in many different ways. You can put contrast in the balloon, for example, and you can see what would happen if you left the balloon for 30 minutes or 60 minutes or 3 hours or 24 hours and then deflated it. What would be the recovery of the animal? And it would at least give a standard approach to testing some of the principles in hematoma surgery, one of which is that the surgery should be sooner, and it would prove that. The other things that complicate intracranial hematoma are the fact that there are chemicals related to the blood in the brain itself, which causes inflammation and other things. But there are, just like your very creative experiment with the glove, this is something that can be done simply anywhere in the world. You don't need anything fancy, and you can find a standard answer to probably one of the major health problems in the world. And maybe some of the students who are on this can think about that or talk to some of the neurosurgeons. But there are, just as shown today, there are examples of diseases we see everywhere that bright people anywhere in the world can find solutions for, and you've presented them.
You see, in the time of Anken, we didn't have any equipment, literally. What we have, they needed repair. We don't have spare parts. So once I was operating on acoustic neuroma and just worried about the facial nerve, my colleague, neurophysiology colleague, we brought a pin, ordinary pin, and connected it to wire, thin wire, and then we used that as a probe to stimulate the nerve and find out if there is any reaction there, contraction. And it did work all right at that time.
Excellent.
I think the student, let me just say one more thing. I think the students should listen, because from your presentation, it shows that you don't have to be think that you cannot make great achievements because you can't do the same things as people in countries with lots of money.
Yeah.
It doesn't take money. It takes brains. It takes creativity. It takes determination, none of which you can buy with money.
That's right. Absolutely right.
Actually, I would argue that the money actually inhibits innovation. Because you rely.
I think you're right.
It spoils people because they just throw money at it and try to solve the problem.
I think you're right.
Yeah, it's all the same when you have only one set of clothes and you have to go twice with the same people. You actually articulate all the possibilities, no? A different tie or turn the tie up. I mean, you do all those things. Absolutely, I agree with you, Asaf. Money sometimes blocks the creativity. Yeah.
As you can tell, surgical neurology is interested in supporting creative and innovative people anywhere in the world. Well, Dr. Khalili, while Samer's getting that up, I'd like to invite you to be a member of the Board of Surgical Neurology International and SNI Digital. We need people with your experience and judgment and wisdom, and it would be a true honor for us to have that happen.
It would be my honor.
I'll correspond with you once I get Samer to give me your address, but you should be lauded, you should be praised everywhere in the world for what you've done.